Hey, good morning, everyone. Before we get going, I just want to remind everyone to take the wellness survey. I think the Department of Surgery is up to 35%. So 2 out of 3 of you have not done this yet. If this adds any motivation, the Department of Medicine is way ahead of us, and they should never be way ahead of us. I'm going to turn this over now to Dr. Malgore, who will introduce our very special guest this morning and the topic this morning. Thank you.
Morning, everybody. So today I have the privilege of introducing Dr. Sean Roddy. He is originally from Central New Jersey and attended Georgetown, where he graduated magna cum laude in 1988. Seems like a long time ago, but it's really not. He received his MD from Yale University before completing his internship at Harvard Deaconess and moving on to residency back at Yale. His vascular surgery fellowship was performed at the New England Medical Center in Boston. He's a member of AOA and is well published. He's a fellow of the American College of Surgeons, past president of the Vascular and Endovascular Surgical Society, Society for Clinical Vascular Surgery, and the New England Society for Vascular Surgery. He's currently a professor of surgery at Albany Medical College and director of perioperative services at Albany Medical Center. He now lives in Del Mar, New York with his wife, Veronica, and they have 3 children, 1 interested in engineering and 2 now interested in attending med school. Outside of his career interests, he enjoys karate, time with his family, hiking, and skiing. He previously served as chair of the Policy and Advocacy Council on the SVS Board of Directors, and this is where the talk focuses today. He's been the CPT advisor for the Society of Vascular Surgery and the course director for the SVS annual coding course for the last 15 years. Interestingly, his service in this role was extended well beyond the traditional 3 years of service at the request of SVS leadership, when it was decided that his level of expertise in this area was not well understood enough by others to qualify anyone to be his successor. After years of familiarity with his work on behalf of vascular surgeons, and after hearing him discuss changes in reimbursement affecting all surgeons at the most recent Rocky Mountain Vascular Surgery meeting, I knew we here at CU could benefit from his insight. So please welcome Dr. Sean Roddy.
Well, good morning. Thank you, Emily, for that kind introduction. I have no disclosures. The purpose of this talk is to review physician reimbursement and the significant changes that have occurred due to CMS, the RUC, and Congress. So physician reimbursement was rarely discussed 30 or more years ago. Payments prior to 1992 were termed usual, customary, and reasonable, and often paid in full. And then Congress mandated RBRVS, which I'll go through, which enacted governmental control to all physician professional payments, and the private carriers generally followed. Now, if you look at that, you can see an influx here. In 1992, the yellow is the percent increase in administrators. And after 1992, when the government took over, you can see the massive increase in administrators compared to the brown there, the increase in physicians through the years. And with that, the administrative costs soared. And they're larger in the US than in any other country that has what could be termed high income. And the US national health expenditure as a percent of GDP has increased to almost 20% through these years. Now, the Consumer Price Index looks at goods and services and how much they cost over time. And some things go up and some things go down. Most of you have bought televisions, know that televisions have gone down, software, that's gone down in price. But hospital services has dwarfed everything. The only thing that comes in second is college tuition. And as a person who's put 2 through college and has 1 in college, I can attest to that. But if we look at the federal budget, Medicare comprises around 15%, goes up and down just a little bit each year. And Medicare has 4 parts to it. Part A, that's the inpatient hospital care. Whenever we take care of patients in the hospital, we get paid the professional fee, but the hospital has to have the OR, the facility, everything else. That's the technical side. So inpatient services are part A. That's also paid for by a DRG or diagnostic related group. Part B is generally physician services. There's some other things there as well, but physician services. Part C is the Medicare Advantage plans, and Part D is the prescription drug benefit. But today, in my talk, we're focusing not on inpatient or drugs. We're talking about physician services, Part B Medicare. So if you look at all of Medicare payments, about 9% are physician reimbursement. So that's 91% is everything else. So why do we focus whenever anyone is looking at how much we're spending in Medicare on physicians? Well, the reason everything goes back to the physician is because more than 80% of the overall healthcare costs result from the decisions we make. Do we treat someone conservatively? Do we treat them aggressively? Do we order another test? Do we see them in 6 months or a year? All of our decisions have downstream ramifications. So that's why everybody looks to the physician when it comes to Medicare spending. Now, we've had this surge in inflation and surge in the overhead, surge in Medicare costs. The 2020 AMA Biennial Analysis of Physician Practice Arrangements identified for the first time ever that the share of physicians in private practice dropped below 50%. That means most people are now employed because it's really hard to be in private practice anymore because the overhead continues to go up. It's a pretty shocking statistic. Now, again, I asked you in the beginning, why do we not talk about physician reimburse 30 years ago? We didn't talk about it because of this. In 1972, this is a typewriter-written fee schedule from Massachusetts General Hospital for vascular procedures. And in the bottom is a common femoral to popliteal artery bypass. They charged and received $750 in 1972 for that procedure. If you take 2023 equivalent dollars for that amount in 1972, they were getting paid $5,400 for that one surgery. But the 2023 Medicare reimbursement is less than $1,400. That means that they were getting paid 4 times the amount for the surgery. Imagine that. You do one Whipple, you get paid for 4. You do one leg bypass, you get paid for 4. You do one gallbladder, you get paid for 4. So they didn't have to work extra hard, and nobody talked about it at that point. But with all these changes through the years, because things have strained, that's why we talk about it. So let's go through Medicare physician payment. In the beginning, we were paid usual, customary, and reasonable, but there were differing payments for the same service. They varied by physician specialty. Neurosurgeons got different fees than vascular surgeons who do carotid endarterectomy. The East Coast and West Coast had different payment schemes, but governmental payments are constrained. They're supposed to be fair across providers and transparent. They're not supposed to have those differences. So Congress wanted to fix that. So they awarded a multi-million-dollar contract to a Harvard economist named William Shao in 1985. And Dr. Shao produced the Resource-Based Relative Value Scale Study in 1988, talking about how physicians could be paid on a relative scale. Congress reviewed that, liked it, and approved a Medicare fee schedule using RBRVS to be implemented on January 1st, 1992. And that was going to redistribute spending among physicians. In Shao's work, they interviewed thousands of physicians for thousands of procedures in the fee schedule based on mental effort, stress, judgment, time, technical skill, and physical effort. It turned out that the number one factor was time. How long a procedure takes is about 95% of how you're going to get paid in RBRVS. If it takes a short time, the pay is lower. A long time, it's higher. So they came up with the RBRVS reimbursement formula. They created a term called the RVU, the relative value unit. They pulled that from the ether, made the term, and they used that as a way to compare everything we do. Whether you're seeing a patient in the office, doing a procedure in the angio suite, doing an operation, whether you're an internist, a pediatrician, a vascular surgeon, a general surgeon, we all will use this. They created physician work RVUs. That's based on the time and the intensity of work to do the procedure. The practice expense RVUs, that's the overhead to do the procedure. And malpractice RVUs, how likely you are to be sued. Then you sum that, that was called total RVUs. Any of the residents here, when you have a contract, you'll be looking at work RVUs in your contract potentially as a target. Don't confuse that with total RVUs, which is a much higher number. They created what's called the conversion factor. That would be, in essence, how many dollars for one RVU. And then there are multiple areas of the country that have a different cost of living. So they created a thing that's been referred to as the GPCI, the Geographic Practice Cost Index. Where I am in Albany has a lower cost of living than down in Manhattan. In Manhattan, the rent is more, everything is more, utilities. So for the same procedure, there's a modification of payment. So that's more to the surgeon who practices in Manhattan than in Albany. So the formula says total RVUs times conversion factor times GPCI equals physician payment. Private carriers, most of them actually follow this with a percentage. They may up it by 20%, 30%, but they generally follow the Medicare formula so that even though I'm talking about Medicare, it kind of translates to all carriers. Now, the way to change the fee schedule easily instead of changing services would be to ratchet up or ratchet down the conversion factor. If the conversion factor goes up by 1%, every single doctor in the US's pay will go up by 1%. If they ratchet it down by 1%, every single doctor, it goes down by 1%. So that's a way to tweak it. So when this came out, several years later, Congress was concerned about Medicare spending. They thought it might go out of control. So they enacted the Balanced Budget Act of '97, and it created a thing called the Sustainable Growth Rate Mechanism, or SGR. And that adjusted the Medicare conversion factor annually. It compared projected by the actuaries saying how much we should spend and what we actually spent. It's on a target on an annual and a cumulative 10-year basis. And that mechanism used cost of living, number of Medicare enrollees, annual spending to adjust that factor. If we spent less than what they targeted, the following year, the conversion factor would go up. If we spent more, the conversion factor would go down. And it worked out great for the first couple of years because we spent less until 2002. In 2002, we spent more than was predicted. Now, if you look at the Medicare conversion factor on this slide, the orange bar is the actual conversion factor that we've experienced for the last 20 plus years. If you pretend that the inflation rate was applied to a Medicare conversion factor, and that's typically around 3% in healthcare. So if you simply add 3% to the conversion factor from 98 on, you can see that we should be nearly at $80 per RVU, but we're currently at less than 40. So that means the buying power over the last 20 years for physicians has markedly decreased. Looked another way, and this is from the Congressional Budget Office, the Consumer Price Index that looks at those services, like I told you, or the Medicare Economic Index, which looks at healthcare inflation, that has gone up significantly, but the physician change has been minimal. So the SGR, after 2002, started to try and cut the conversion factor so much that Congress had to step in to not bankrupt the physicians of America. In fact, 12 separate distinct statutes were passed that I have listed here. And after each one, which was for a given time period, ended, then the SGR mechanism would want to make up for everything. So the cut would be 5%. And then if a legislation, then it was 10%. Then it was 15% cut. So the cuts became unsustainable. So Congress had to act every year. Congress also told us there is no additional money outside of Part B Medicare that we can put into Part B to get rid of the SGR mechanism. We can only find money to patch. So SGR became a bad word to us. And every year we had to go to Congress to save us. The problem was the last patch of the SGR in 2014, the Protecting Access to Medicare Act, it used physician income to pay for physician income. Now that's a confusing statement. What do I mean by that? Well, they said, okay, we're going to assume that you guys are being overpaid in certain CPT codes. We want you to find them. We want you to cut them. And we want you to find $500 million a year for physician pay that's overpaid for 4 years. So you can find $2 billion that you would have been overpaid. And we'll use that to patch the conversion factor for you. And so we were kind of shocked there. Uh-oh, Congress has decided that they will no longer take external money. We're up a creek. So this was enacted in 2014. They were going to give us a couple years to get it. So we had to find 500 million in 2017, 18, 19, and 20. But then before we even got to that, the ABLE bill came out, the Achieving a Better Life Experience bill. Now that bill has nothing to do with physician payment. It creates tax-free savings accounts for individuals with disabilities. If they want to make a ramp, if they wanted to buy a wheelchair, there's a lot of things that people with disabilities need. But when you do a tax savings account, you decrease the amount of money that the IRS sees, tax income. They said, how can we find the income that the IRS needs? Okay, let's take it from physicians. Where did that come from? So they decided to come from physicians, and they said, okay, the way we can pay for this is we're going to move the target up. Now, you see the top is how we were supposed to get $500 million in 2017 to 2020. They said, we'll just move it up. So you guys have to find us $1 billion in 2016 and then $500 million for 2017 and 2018. So now we're at this untenable situation where we see that we're not getting extra money in. We have a 20% conversion factor cut in April of 2015. What are we going to do? And then talk of MACRA came around. SGR reform, abolishing the SGR. So remember how they never could find money to get rid of the SGR? Well, they couldn't find it. So they just said, all right, we're just going to make it so we're going to increase our federal deficit and we'll just write it off. So all those years they couldn't do it, they just added to the deficit. And they said, all right, we'll give you a 0.5% increase for 5 years. And then we'll give you a 0% increase for 5 years. Now, that's a little bit of a loss, right? Remember, I just told you 3% is the cost of living. So we are losing out. We're still losing buying power, but at least we're not losing 20%. And in my world of reimbursement, you got to take what you can get. So we either have 20% cut or we got 0%, right? So we went with the 0%. So we all the medical societies agreed with it. Unfortunately, they didn't repeal that ABLE bill. So we did cut everybody. But after MACRA, we were fairly stable until 2020. Now, let me stop there, and I'm going to move to a slightly different topic, the revenue cycle. In my world of medical societies, and whether you are a thoracic surgeon, it's the STS, a general surgeon, that's the American College, a vascular surgeon, that's the SVS. There's all representatives that take care of reimbursement. We all work together. We work together as a surgical coalition. We sometimes work with our medical colleagues, and me with endovascular. I work with the cardiology and radiology colleagues. So we all work together on this. We take care of services. Now, that's what I refer to as any physician-patient interaction, whether that's your kid seeing a pediatrician evaluation, you seeing the internist, doing a surgery. Those are called services in my world, and every service must be defined. So the American Medical Association owns CPT, and CPT makes the codes, the 5-digit numbers that describe services. So part of the revenue cycle for me is making sure we have the appropriate CPT codes. We have to define the service. Once we define or redefine the service, then we have the RUC. What does RUC mean? RUC means the American Medical Association and Specialty Society Relative Value Scale Update Committee. Much easier to say RUC than say, that's a mouthful. So the RUC values CPT codes. It creates how many RVUs, what overhead is in that. And they act as an expert panel and then send that data to CMS. The government, the Center for Medicare and Medicaid Services, looks at that and decides if they agree with the RUC or not. And they publish each year the RVU content of every CPT code. So it is CMS that finalizes everything. They publish what's going to be for the following year in November. So this coming November, 2024, they'll publish for what's going to be January 1st, 2025. And then in follow-up with the revenue cycle, RUC and CMS screen these codes for misvalued services to look if things should be changed. And then we as a body have to look at coverage decisions made by private and governmental carriers for what gets paid and what doesn't. So if you look at CPT, that's a 17-member AMA-appointed panel. I am leaving here this evening to go to San Diego to one of the CPT meetings, which is occurring there. At that meeting, there will be code change proposals. Anytime we want to create or modify a CPT code, we create them, and it gets presented to that body. I am a specialty CPT advisor. I represent the SVS. When I present, that body either will accept, and it will go into the next year, the designated year's manual. They will reject it, and we'll have to start again from scratch, or they'll table it, meaning that we have to tweak it, and we can come back either at that meeting or at a future meeting. Keep in mind, many of you are involved in research and new technology that comes out. When a new technology comes out that does not have a CPT code, we want to create one, but we cannot create it until it's FDA approved. And after it's FDA approved, we have to have 5 non-overlapping studies, non-overlapping authors, non-overlapping patient populations, and 1 has to be US peer reviewed. So we've had many a time where it got FDA approved and there were only 3 major studies. So now we have to wait until those studies are published in peer-reviewed journals before we can actually apply for a CPT code. Now, the RUC is a 28-member volunteer physician advisory panel. They act as an expert panel. They only send the information to CMS, and CMS chooses to believe it or not. 16 medical, 12 surgical, and it's based on surveys. Physicians in medical specialties will get a survey by email. In it, it asks how long it takes. Remember that time that I talked about? It shows you different CPT codes. It's a relative value scale. It has to be set between. So is it a little more than this? And is it a little less than this? So you have to help sort that out. We have to have a return of a minimum number of surveys to be able to value a code. We get about a 1% return on our surveys, okay? We have had to cancel changes to a CPT code for the RVU value because we didn't get enough surveys in the past. I'm not allowed, once a survey goes out, to coach people as to how to fill it out. There are rules on that. All prior surveys are kept in a thing called the RUC database. And I want to give you an example here of how this works. A femoral tibial in situ bypass has an intra-service time in the RUC database of 305 minutes. That means it's a 5-hour procedure. Okay, its length of stay is 7 days in the hospital, and its postoperative visits are 3. If I sent you a survey and you said it's now 4 hours, we would have to cut that by 20% because it was 5, now it's 4, 20% less, 20% less RVUs. If you say it's now 6 hours, that's a 20% more, right? So it's really based on how many hours that is. And many surgeons beat their chest and say, I can do that in 30 minutes. Okay, well, you'll get paid for 30 minutes. So be honest on the surveys so we can get the appropriate value. After the RUC, CMS gets the report. The fee schedule is typically published in the first week of November, and then CMS decides to accept or modify the RUC with rationale. So when I talk about a revenue cycle, we talk about the year in which it's going to be effective. When I go to San Diego, we're in the 2025 cycle. So what I work on will be in the 2025 manual. So the CPT meeting in February goes to the RUC in April, and you can see there's a corresponding one to each. It's published online. This is a snippet from the PDF that's published on the AMA website telling deadlines for submissions of these applications and when the RUC meetings are. And the shortest amount of time from when we submit to getting a CPT code, again, think about new technology, FDA approval, we've got everything. We go to the CPT. If we submit in June of 2024, it would be the September 2024 meeting, the January 2025 RUC, the November final rule, and January 2026. So it's a minimum of 19 months, almost 2 years after the technology is FDA approved before we can get it. So it's wonderful when that new technology can be in a current CPT code, so we don't have to try and get a new one. It helps with reimbursement. It also helps with utilization because many people do not want to do it if there's no code because lack of reimbursement. So let me now move to code maintenance, the RUC, CMS, and misvalued services. Now, the Omnibus Budget Reconciliation Act of 1990 required CMS to comprehensively review all relative values at least every 5 years to make adjustments. It was termed the 5-year review. And all of the codes are open for public comment. If any person sent in that carotid endarterectomy needed to be reviewed, boom, it's on it. It doesn't have to be a physician or a medical society. It's open to anybody. In the first 5-year review in 97, 1,000 CPT codes were reviewed. The second one in 2002, 870. The third in 2007, 750. And it turned out that the majority of codes had no change or an increase in their RVU content. So MedPAC, an advisory committee, they comment to CMS and to Congress. They found in their March 2006, as well as repeated in the 2007 and 8 report, that there's a bias in the 5-year reviews in favor of undervalued codes as opposed to overvalued codes. And this was the tipping point to now start screening the fee schedule for misvalued services. And so MedPAC recommended establishing a separate standing panel of medical economic experts to identify these overvalued services, suggested the panel could use statistical analyses, and said that increased growth, because physicians are smart people and they'll find out what pays well, if there's growth, that might be evidence of misvaluation. And so in response, the RUC created the 5-year identification work group to look for these using standard mechanisms and statistics. Now there is no further 5-year review. It's literally every year we do it. We don't just do it every 5 years. And they renamed that they renamed it to a relativity assessment work group, or the RAW. So at every RUC meeting, the RAW meets and we find out what might be cut, what has to be resurveyed, what has to be assessed. And the RUC meets, 3 times a year. So I've just put here a couple of the screens. It's not meant for you to go over everything. Just want you to see growth is a big thing. And site of service anomalies, I put this here. That's an example. I'm going to give you an example of one that had to be revalued. So all CPT codes have the intra-service time, but they also say whether it's in the hospital. If the patient stayed in the hospital and had a post-op visit, the E&M code for rounding on the patient is embedded into that. Okay. Now, if a procedure was done as an inpatient for years, but now is done as an outpatient over 50% of the time, everything in billing and reimbursement is based on over 50%. So when the screen went out, upper arm basilic vein transposition for hemodialysis access creation used to be everybody stayed overnight and went home the next day. But when this screen was run, it had changed to be an outpatient procedure over 50% of the time, and it had inpatient rounding codes on it. So it was flagged, we had to resurvey it, and we had to remove the extra money from the rounding on them because the majority of times you don't round on them. So that's an example of how this works. So the bottom line is any service that hits a screen has a distinct possibility of being revalued, and revalued generally means devalued. So when a single code is revalued, CMS and RUC make us reassess the family. So when the basilic vein transposition gets hit, that means every dialysis access creation gets hit. If cholecystectomy gets hit, every cholecystectomy has to be re-reviewed, okay? You have to maintain relativity, and you can't change one without looking at everything to make sure they're all line up. So the strategy, of course, is to avoid being screened and defer. So how effective has the relativity assessment work group been? Well, 2,751 potentially misvalued services have been screened to date. That's about 95% of the allowable charges in the fee schedule. 40% were cut, 25% were reaffirmed, 11% increased, and 18% were deleted, sometimes because we bundled codes together and sometimes because the service just really wasn't applicable anymore. They recommended reductions and deletions to 1,600 services and took $5 billion of physician pay and redistributed it to the fee schedule. So it's been pretty effective. In fact, here's an example of how effective it was. The cost per Medicare beneficiary for Medicare was on a trajectory going up and up. And you can see around 2008 to 2010 is when we started doing all of this raw 5-year review. And you can see that the cost is the black line, the reality up to 2014. You can see the divergence of what they predicted, $188 billion spend down, okay? So the payments were cut. It was very effective. So now I'm going to move to what we're currently dealing with for the last few years. I told you that MACRA had stabilized everything to 2020. But Medicare was tired of doing audits and hearing complaints about the note bloat, right? Copy, paste, family history, social history review of systems. Every time, copy, paste, the notes became absurdly long and they weren't providing any additional data and it was becoming a burden. So they wanted CPT to reassess CPT codes for office visits, both new and established. Again, when you see people in the office, we do that. Medicine, internal medicine, that's all they do, right? If they're in an outpatient facility, pediatricians, but we do that as well. So changes were made to remove the requirements for note bloat. It's now based on time or complexity of decision-making. Now, when CPT codes are changed, they have to go back to the RUC for revalue. There were resurveys, and there were significant increases in the values. So from the first pass, that sounds great, right? We see people. I guess the internists are going to see a bigger, because that's what they do. They're going to see a bigger improvement than we are, but we're going to get an improvement in our income. We're going to see the same number of people. We can document less, and we're going to see more RVUs for what we do. Okay. Unfortunately, when this went through, CMS did not pump any additional money into Part B Medicare. So if you have one pool, if something goes up, guess what? Something else has to go down. We term that a budget neutrality adjustment. It's a fancy way to say that something that we do is going to get cut. The budget neutrality adjustment was that we had to lower the conversion factor. Remember, I just told you that the conversion factor, if we lower it by 1%, that means every surgery you do goes down 1%. If I say 2%, it goes down by 2%. CMS also for 2021 said, not only do we want to give more money to the office-based, we believe that primary care is grossly underpaid. So we want to create an add-on code for primary care to take care of complex patients. This add-on code is going to be a G code. That's a government code. That's one that not the AMA didn't create, but they're creating. And they would report that in addition to the E&M code, the office visit code, and that would provide them additional compensation for their work. That G code actually required a cut similar to the amount of the E&M services. So it was a double whammy. All right. In fact, that added up to a 10% cut in the conversion factor. So that means every surgery you do would be 10% less compensation. So of course, we complained to Congress. We talked to there's a group of physician congressional leaders. We call that the Doc Caucus. So the Surgical Coalition, the American College of Surgeons, and the specialty surgical societies together lobbies the Doc Caucus. They hear us. They provide the information to the rest of Congress. It turned out we were able to get some changes in the Consolidated Appropriations Act of 2021. They delayed the add-on code for 3 years, right? So that's 2021. So if we ever get to 2024, that's when it's going to come back. Oh, wait, that's today. It added 3.75% to the conversion factor as a fix for 2021. So therefore, the conversion factor dropped not 10%, but only 3.3%. We didn't get a 3.3% cut in all of our pay. Remember, we got the additional income from seeing patients in the office. So if you do the calculations, most surgeons had about a 1% cut in pay, as opposed to the 6 to 7% that we would have gotten should the conversion factor go down by 10%. So now we get to 22. That 3.75% improvement goes away because it was a one-year patch. Doesn't it sound like the SGR again? Here we are. We just sold our soul to get rid of the SGR, to get rid of lobbying Congress at the end of every year. But here we are going back to Congress. Now we have that one-year patch goes away. We have a 3.75% goes away. And they also say, so for various reasons, budget neutrality. Oh, it goes down by 3.85%. So again, we're going to go to Congress. But we've got another issue. We had COVID. COVID required us to spend $2 trillion. But PAYGO, the Statutory Pay-As-You-Go Act of 2010, the budget enforcement mechanism that ensures legislation passed by Congress and signed by the president doesn't increase federal deficits. So it was supposed to increase a lot, but Medicare payments cannot be cut by more than 4% by statute. So we're supposed to get a 4% cut in 22 on everything we do, affecting everybody in medicine. So Congress steps in again, and they say, okay, I know last year we gave you 3.75. This year we'll only give you 3%. But as a bonus, we'll delay PAYGO 1 year until 2023. Sounds great. Now we get to 2023. The conversion factor is now set to drop about 4.5%. We lose the 3%. And then there was some projected growth in spending. So again, that budget neutrality fudge factor that keeps coming in there makes us drop to about 4.5%. And PAYGO is supposed to come back. So again, we lobby to Congress. Here we are back lobbying again at every year. So they passed the Consolidated Appropriations Act of 2023. And they say, okay, we'll push PAYGO again 1 more year to 2024. And we'll give you 2.5%. Now remember, it was 3.75 they gave us. Then they gave us 3. Now they're giving us 2.5. They also put in there, they said, next year, we don't want you to come back. So we'll give you 1.25 next year for 2024. So they put that in the 2023 legislation. So you can see there's a steady line of that they're, in essence, we're going to accept this cut that they want. They're just trying to do it gently. All right. So the finalized conversion factor for 2023 dropped by 2.1%. Now here we are in 2024. That add-on code, now it's coming back. It was originally just for primary care. Now it can be for anybody who takes care of complex patients. There's a whole host of requirements. So don't think you just bill it because you're a vascular surgeon, you take care of complicated patients. So be careful about that one. It's assumed to be billed with 38%. That's the CMS calculation, which is markedly less than what they had thought back in 2021. So the amount of cut that we're going to see from that is less. So because the budget neutrality impact of adding that G code, G2211, that increases the cut from 1.25% to 3.4% for 2024. So again, 2.2% budget neutrality cuts, we lose the 2.5, we gain that 1.25 from the last year's legislation. And the finalized cut for this year that you're experiencing is a 3.4% cut, and you have PAYGO. So I've just told you a lot of depressing news. I know you have a negative visceral response. Please don't shoot the messenger here, right? But other people noticed as well. In fact, remember, MedPAC is the body that recommended that we start assessing misvalued codes because physicians are getting overpaid back in 2006, 7, and 8. MedPAC actually, in their annual report to Congress, is very concerned. They recommended that they increase the Medicare physician payments above current law by linking the payment update to the Medicare Economic Index and paying us for the inflation. This is the first time we've actually had a congressional appointed body recommend to Congress to do that. So we're trying to use that in lobbying efforts. Also, the Medicare trustees report recently said lawmakers should expect access to Medicare participating physicians to become a significant issue in the long term because Medicare payment is becoming so horrible. So we have two independent bodies that advise Congress, advise the president, and advise Medicare are saying it's gone too far. So there's lobbying efforts, right? Multiple societies individually are lobbying. Additionally, the Surgical Care Coalition is lobbying as a group. We're looking for a conversion factor increase, this budget neutrality reform that keeps hitting us, clinical labor patches for those of you who have an OBL, an office-based procedure, there's some changes there, and this add-on code. The only solution to these cuts is legislative. There's no way around it. So political action committee donations for your societies now matter more than ever. So in conclusion, the growing cost of healthcare has translated into significant efforts to control spending. Physician payment over the last several decades has seen tremendous change, as I've tried to outline. Recent EMM changes, pay-go budgetary enforcement mechanisms, and budget neutrality issues have shifted compensation away from proceduralists toward office-based physicians. And physician input and lobbying legislators in this highly political process is critical to help maintain reasonable compensation. Thank you for your attention. And again, I emphasize, please don't shoot the messenger. Just trying to detail a summary of what you've experienced over the last several years.
That's great. Thank you. Lots of information. Let's take some questions. Dr. Schulich.
So, Dr. Roddy, thank you so much for coming and presenting. This is just such a complicated area. Every time I listen to a talk like this, I learn more. And, there's no way for me to really totally understand everything. But, the way you presented it today, giving the history and explaining the general effects is so important. My question to you is 20 years ago or 30 years ago, did you ever think that this was going to be a big part of your career? And, how did you get here?
Sure.
I mean, obviously, this is so important. And I think we're paying the price for physicians sticking their heads in the sand, 20, 30 years ago. And really the only solution to get out of these issues is to have people like you on it and lobbying for vascular surgeons and surgeons in general. So thank you.
Sure. Thank you. So obviously I started with my medical school residency and fellowship. I want to do case after case after case, be a case hog. I got to do this. I got to do this. I started in practice in Albany, a high volume center, doing hundreds of open aortas, leg bypasses, carotid endarterectomies. That was my, quality outcomes. That's all I cared about. And then somewhere around 4 years into practice, I went to the head of our group, Diraj Shah, and I said, hey, how do we get paid for all this stuff? And he said, I don't know. I was like, what do you mean you don't know? How can you not know? You run a group. We got 8 vascular surgeons here. You don't know? And so I Googled a couple things and I saw that the American College of Surgeons had a coding course and it, advertised that you can understand how you get paid. So I said, all right, well, Dr. Shah, can I go down and see that? So I did. It was a one-day course at Newark Airport. So I drove down from Albany to Newark, New Jersey, and I went there for the day. And I realized that what we were billing was all wrong. What we called a profundoplasty, meaning that you just extended the anastomosis onto the profunda from the common femoral, our billers were billing as an angioplasty of a blood vessel. And so I started looking and I found that like over 50% of what we were billing was wrong. And, I'm a numbers and data guy. You could probably tell from all this stuff. And, I was thinking about computer science. My brother's a vice president of Google. We family genes here of the numbers. So I just started looking at it more and more. And then I started asking Bob Zwolak, who's one of the forefathers of healthcare policy and vascular at Dartmouth. Every time I found him at a meeting, a medical meeting, I annoyed him with a question. And then after a year and a half of questions, he said, we're expanding our health policy committee. And this is in 2006. He said, so you asked me more questions and more complicated questions and so many questions I can't answer. I'm appointing you to the committee. So that's how I got involved. And then 1 year later, he said, you're doing so well, you can run health policy because I'm going to become president and I have to step down from running this. And you can, by the way, you can run the coding course. So maybe I was just in the right time, right place or the wrong place at the right time, however you want to think about it. And that's how I got into it. I think you should realize that there are people in every society that will do health policy. And we do it because we want to slow the fall. Right? If we can, and a lot of the things that we fix, we can't publish to you because you can't say, hey, I just improved $10 million in payments to vascular surgeons. And I kind of, Medicare doesn't realize it. You can't publish that. That's not a thing. So, but it's those wins that we celebrate. We have a bottle of wine together and we work well together. It took me 5 years minimum before, I was running the committee, but yet Bob Zwolak was kindly, when I said something that was wrong, would go, well, Sean, there's another way to think about it. That means, you're totally wrong. And he's just trying to be nice. And he would, so it just takes a long time to get to know the abbreviations and what goes on. And that's why you can't have somebody rotate on the coding committee for 3 years and go off and then another person. You need a little bit of historical memory there. But thank you.
Yeah, the acronyms and all that are very confusing, and I think you presented it in a very clear fashion. But the question was, how did you get to this? What is the expanded role for our own individual understanding? There's a lot of people in the room here who are going to have a range of interest or not in this. And how do you raise that level to really change what the economics are? Not just maybe politically, but other aspects of healthcare spending and how we practice?
Well, there's so many ways to answer that question. I mean, I think it's important for individuals within any group to have at least somebody who is savvy enough to understand the CPT RUC process. I think it's important for medical societies to publish emails and summaries for people so that they can stay informed. I think it's important for people when they get those to not do the jerk reaction of just delete, delete, delete. It's another email and I got to get home to my spouse, right? I mean, I think there's so many levels of that. I think there are coding courses that describe all of this with every society. Neurosurgery has one. STS has one. ACS has one. SVS has one. They even offer discount rates to students, residents, and junior attendings, right? And a 1 day course or a 1.5 day course like that can actually open your eyes, because I'm only talking to you for 45 minutes here, but that's an 8-hour day of hearing things in more detail, and you can understand some more of the nuances so that you can pay attention. It's so confusing, just like anything. When we start doing a procedure, the resident doesn't get it the first time, doesn't get it the second time, then they get a little bit the third time. So you got to do that FemPop bypass over and over and over again before you really understand it as a senior resident and chief resident or fellow, right? So you got to hear this over and over again. You got to pay attention when your society has a lecture on it. You should listen. We're also so overwhelmed with emotional negativity when I or someone like me starts talking that you're so angry that you literally can't pay attention, right? You get this visceral response. Who can do this to us? This isn't fair. Who can I call, right? Nobody, you have to settle down and say to yourself, let me just take it in. Some of my partners are brilliant, but they don't know this at all because they just get so angry anytime I talk about it, right? Oh, I'm sorry, I forgot.
Thanks very much for the presentation. There's one question I've had for many years that I've never had anyone able to answer it. And so hopefully you can.
I don't know. It's a tough.
Are there any empiric data that says that controlling the 9% has an effect on the 80%? You said it early in your talk that the reason physicians are the focus of this is because we control the other 80% of spending. But I'm not aware of any data that says that changing the 9% reimbursement affects the 80% of the expenditures in Medicare.
Yeah. So I quoted an article where that was stated, but I have never personally looked at that article. So if you look at my slide, there is an article at the bottom, and maybe that would have it, but I don't personally know. I'm not aware of any specific data about that. So I'm sorry, but I think I failed you.
I've seen many opinions and editorial pieces that have asked this question, and to my knowledge, there are none. So the whole premise of controlling that 9% affects the 80% seems to be something that no one has really ever looked into.
Yeah. The other issue is that hospitals continue to see a 1% increase, 2% increase. They have much more lobbying power. Physicians, for at least the beginning, thought of it as taboo to talk about reimbursement. And then once they started getting cut, most people don't want to give $500, $1,000 to a political action committee to try and lobby. So the lobbying power of physicians is massively less than other organizations. If you look at a chart, the American trial lawyers for malpractice, they have this much, and surgeons have this much. Okay, so you can see why malpractice reform doesn't happen. I have experience interacting with congressional leaders. Carotid duplex was going to be changed. The technical fee for reimbursement was going to be changed. All of the ultrasounds are listed in a row, right? And the technical payment, and there's a line, and above you get higher and below you get lower. And if you switch that line, something could be moved from the higher to the lower. So Medicare switched the line and carotid duplex was going to get a cut. To try and get that changed, you had to talk to congressional leaders. How do you talk to congressional leaders? The only way to talk to them is to donate to them and go for a lunch. So I was flown down to DC. There's a GI physician who's the senator in Louisiana, and they donated $1,000 for me to have this boring chicken sandwich and sit in a room with about 10 other constituents, one person from the alcohol industry, one from a steel industry, and you get about 3 minutes to say what you're going to say. They literally go around the room. So in 3 minutes, I had to explain what we're doing and what our concerns were. I did, and he turned to his LD, the legislative director, and nodded and said, put it on the list. What that meant was tell the other doc caucus that we need to send a letter and have Medicare move the line. And we did. So that $1,000 chicken sandwich, plus my airfare to go down and back in my time, translated into 10 million in savings for vascular surgeons who own vascular labs. So if you don't pay, you can't play, right? And if you think you can just go to a congressional leader and just talk, you can't. You literally have to pay to see them. It's the reality. So because we have such little PAC, physicians have lagged, and the American Hospital Association and others have so much more buying power because of their PACs.
Dr. Christian.
Hi. So speaking of some of our other partners in healthcare, like hospitals, there's a lot of attention to quality of care and high value care, which is a little bit at odds with some of these calculations that are based off of time or effort or stress. And so what is the conversation happening at, this high of a level about radical changes to the system that actually look at value and quality and outcomes?
So, when MACRA was implemented, MACRA created all of these organizations to try and have quality and be paid for quality. And all of them have not really demonstrated an improvement in care and a cost savings. So the first pass, which everybody talked about in 2015, 2016, that's all we talked about and all we were concerned about, that has actually kind of failed. So yes, physician payment is broken. And yes, quality is probably a better way to pay for, but no one can figure out how to make it fair and with numbers and adjudicate. And so that first attempt with MACRA has just been horrible. But your point is well taken. That's where we should be. I shouldn't be paid more because I do 2 bypasses because my first bypass failed, right? We should be paying more for the person who got 1 bypass and saved their leg. But the way a system is set up is that I get paid more if I have complications than I do if I don't. And that's not really the way we're trying to push healthcare.
I don't know.
Yeah, so the fortunate thing for me with this is that I've been present since 2006. And a lot of these cuts started in 2006, right? That's when the MedPAC. So I just had to do a little research to find out how we got to 2006 with the 5-year reviews and the improvements. Because when I started, vascular was undervalued at the original 1992 coordination. And so that's all I focused on. But going through it directly, going to the meetings, helping to fill out letters to Medicare, meeting with the congressional leaders, it's helped. So the majority of my talk was literally during when I was doing all that. So it was pretty straightforward for me, just kind of talking about what's happened during your reign as the health policy and governmental relations chair. So it became pretty easy.
I'm going to ask a quick question. So where would we see these surveys coming in where we contribute, number one? And then, because I feel like now that we're all feeling empowered to be proactive, we're going to want to fill them out. And 2, what would be a tangible first step that each of us could take to get on this path that you started? You mentioned some of them, but maybe being in the AMA or maybe in our regional meeting, something like that.
Okay, so whenever a procedure is going to be revalued or a new one's created, your medical society will say, yes, our members perform this service. And then the people who are my analog in that society will then say, okay, we have to generate a list of people who we can send the survey to. In years past, people would mail it. Now we do it electronically by email. So sometimes societies will choose to send it to everybody. But for example, fenestrated endografting is a fairly specialized. And so we have to petition the RUC to say, we'd like to get a list of the leaders in the field and send it to them. And we have to get pre-approval if we want to do a targeted survey to people who could actually fill out the application, because the average vascular surgeon might have trouble filling out something about a procedure that's only done in limited institutions, okay? So it's really comes down to your society as to who they send it to. When they send it, it usually has a subject of RUC survey. It's a long survey. It's one of those where it's going to take you 20+ minutes to do. So again, that people even start it and then they hit delete because they're just fed up with it. Again, we're not allowed to coach. So that's the problem. Then they'll send us an email and we can't really answer it. We have to leave it as it is. So that's what makes it frustrating. So if you see an email that says from the name of a person in your society that you recognize, and it says RUC survey, that's probably it. I'll just tell you, please be honest. You know that the OFAT takes a long time to get the patient ready, right? That obligatory fooling around time, the anesthesia time beforehand, right? You know the positioning takes a long time. You know when you work with the resident, it takes longer. You know that getting the patient to PACU takes longer. Okay, don't beat your chest. I'm not saying lie and say it's a 14-hour operation for a gallbladder, but I'm saying you should just think about how long does it really take on average and fill that out. I want you to know that what the RUC has accepted as the norm is you fill it out and they take the 25th percentile. So if I send in for 6 hours, 75% of people are going to send in more than what they're going to accept as the actual value. They take only the 25th percentile, not the 100th or the 75th or the 50th. You would think in statistics, we should use the 50th, but the norm is to accept the 25th percentile. And what was your second question?
What can people do today to get involved?
You get involved. So the way it works, at least in the SVS, the Society for Vascular Surgery, is that every year before the annual meeting, there's an email that goes out to any of the members, student members, resident members, PA members, the just standard, attending members. And it says, do you want to be involved in what societies? And it has a whole list. And you fill out that survey, you fill out that form. And so people are chosen from that list. And you have senior colleagues. Those colleagues know the people who are on the committees. And so I can't tell you how many people would call me up and say, hey, we have my first year attending, my fourth year attending, he's a sixth year attending, he really wants to be on this committee, et cetera. And so we usually take people who are interested and apply. But at least in the SVS, you have to fill out that form. You can't just ask to be on it. You have to fill out that. So there's probably is. I think John Matsumura had a.
Yeah. Thank you so much, Sean, for the work you're doing. Kind of makes me ashamed that I declined my MedPAC invite when I was a division chief. But Mike, I have one comment to follow up. You said you can't coach, but I would tell all the surgeons in this room, you need to answer that survey and use a typical patient. Don't think about your best case, your typical patient and the amount of work, and pay specific attention to the amount of time. Because as he said, that's 95% of the value of that. And I think it's really important we do that. I think we can join the AMA again. That's membership by specialists determines House of Delegate representation, which helps us get a position back on the RUC. Sean gets to present, but he doesn't get to vote. And I think it would make a huge difference if we had more surgeon specialists voting on that. And then the other area I think is the PAC. A lot of us, you think it doesn't work, but it really does. Our competition in this single pie is submitting to the PAC. Their PACs and it's one pie. But my question is, G2211, did you say that specialists can start using that? But you gave a little bit of caution about that. Could you elaborate?
Well, I have not gone through the requirements at this point. They opened it up to non-primary care to report. But the intention was the medical outpatient long-term care. So the details, at least even in the fall of 2023, were not clear as to what CMS was going to mandate. So my caution is only that I haven't read it. So I just don't want everybody to immediately think that they can go report that code. You have to look at what the requirements are to make sure that you're fulfilling all of the requirements to submit it. That's my only caution. Again, we have long-term care of patients with vascular disease in vascular surgery. We take care of complex problems. I'm just not sure whether the requirements that CMS are creating will gel with what we typically do. And so that's the caution I'm saying. I don't want anyone to, oh, I heard Roddy's talk and I, build it and then all of a sudden you're audited. So that's all I'm cautioning. Okay. Thank you.
Thank you so much, everyone, for staying late. I think this talk was excellent, and I personally feel more empowered. I think probably all of us do. This is a gift from us, so you don't forget about us. There's a little bit of swag in there.
Swag.
Your CU tie and some other things, but we just really appreciate everything.
Awesome. Yeah, thank you. Thank you. Cool. Cool. My daughter's all about the merch in college, right? All about the merch.
If
Dad.
you need a water, grab one. I know you've been speaking and
Awesome.
turn this up.